Okay, we're going to get started in just a minute. We could get all the panelists up to the stage for the 2 o'clock panel. Yeah, hopefully it's in the slide deck, the presentations.
Yeah.
We hope. I'm waiting until they turn this on so I can move it.
Hi, you're going to be on this panel as well? You're going to be a speaker on the panel.
I have both, I don't have one.
You should ask. You should go and get one probably. We share. Oh, you're going to share. Yeah, I don't have a policy. And you are from Tunisia? Yes. I see.
Okay, we have everybody? All right. All right, everyone, welcome back from lunch. To those online, welcome back. Unfortunately, for those in person, we still have no water. I'm told that we should have it around 3 o'clock, and I don't see the work crews outside anymore, so that's good news, I think. But welcome back. Hope you enjoyed your lunch. And we are now going to continue with our sessions, and this session is the new normal. And how can we meet patient expectations in this new normal? And so what we want you to consider in this panel is that we heard from the first panel, and thank you, Penny, for telling your personal story, that we really are, in fact, living in a new normal. And as everything has changed, so has a patient's expectations of the healthcare system and of their disease management. And so, as I said earlier, dinner conversations have changed. Everybody's now talking about vaccines and masking and viruses and things of that nature. So the real question is, how can the major stakeholders in healthcare work together to meet the expectations of patients? And we have the major stakeholders in healthcare right here on the panel. We've got these fantastic speakers. From the WHO, from the International Council of Nurses, from the World Federation of Public Health Associations, and the International Hospital Federations. These are the major stakeholders in healthcare, and they're going to talk to you about how we can best meet patient expectations. And because we have limited time, I'm not going to go through each of the bios, but all of you can look at the bios online and see these excellent speakers. So what I'm going to do is tee up a question for the whole panel. And then I'm going to hand it over. To our first speaker, who is Manhar Latif from the WHO. I'm sure I said your name wrong, and I apologize for that. But I'm going to ask the question to the whole panel, and that question is really, what do you consider is the most important prerequisite for meeting patient expectations in the new normal? Sir, take it away.
Yeah, thanks. Thank you, Mr. Chair. First of all, I would like to thank the World Patient Alliance for having me here with you. I wanted also report. It's a summary report about a rapid review that we conducted like 6 months ago with WHO on the implication of the COVID-19 on patient safety. So the aim was to explore the impact of COVID-19, to establish the main patterns and the methodology that needs to be with the consultation with the different advisors. So as you know, the health system, we have in health systems, we have 6 building blocks. We have the health services, we have the health and safety of health workers, we have the patient and family and community, including inequities, the leadership, governance and financing, the communication and the development and supply chain of medical products and vaccines. So this is the framework that we used in order to extract the key messages and the learned lessons that need to be considered for ensuring patient safety from the health system, learning from the COVID-19. So the COVID-19 has had a positive impact on patient safety in terms of leadership and culture, in terms of vaccines and diagnostic. We manage it despite all the challenges. Vaccines are there, and they were there in terms of allowed reducing the incidence of the COVID. Service delivery transformation were quite rapid. Awareness of the overall health, self-care and digital literacy, health workers' safety has become now more and more important, industrial development, digital transformation and innovation, overall approach to managing the pandemic. We know what needs to be there in order to get well prepared for managing the pandemic. These are the positive sides, but we have some negative sides in terms of risks and harm to in health services. We have the healthcare associated infection that has increased. Same for medication safety, diagnostic errors, surgical safety, patient falls, pressure injury, COVID-19 immunization errors, antimicrobial resistance, and you were highlighting this in terms of as a consequence of the overuse and misuse of antibiotics, other hospital-associated risks, telehealth with the risks, safety concern for COVID-19, diagnostic testing, collateral effects of care disruption, the diagnostic and treatment delays from deferred acute care, diagnostic and treatment delays from disruption in routine care, and impact from disruption in preventive care, screening, and immunization programs. The COVID-19 pandemic has also other key areas like health and safety of health workers, and we know now that more and more attention is being given to the safety of healthcare workers, highlighting the main in terms of physical, occupational health, and something that is also being more and more highlighted, which is the mental health of health workers as well. Patient and families and community, including inequities, the communication due to this, you said, we said this, the virtual consultation, the communication was not the same, so it has led to not an effective engagement with from the community in order to take care of their patients. Leadership, governance, and financing. There is a need for further reinforcing the leadership, the governance, and the financing, so that in terms of managing properly the pandemics, communication and management of health information, development and supply chain of medical products, vaccines, and technologies. So the key lessons learned about patient safety. Now we know, we now know that much more about the pandemic related to safety gaps across all care components of health systems. We know that also a greater understanding is still needed about the risks and magnitude of avoidable harm in COVID. Disruptions to systems and processes of care accentuated known safety risks and harm in healthcare and introduced new ones. Loss of capacity of health systems necessary to preserve essential health services. Managing COVID-19 in countries experiencing fragile, conflict-affected, and vulnerable settings. We need to give more attention to the situation in countries that face emergency, that face natural disasters, conflicts and wars, where the approach should be adapted to these contexts as well. The pandemic led to avoidable direct harm to hundreds of thousands of health workers around the world. Misinformation and disinformation need to be given attention. The pandemic exposed long-standing health inequities impacting patient safety. Lack of interaction between patient families and health workers, together with exclusion from decision-making, and the most consequences in terms of the pandemic were negative for patient safety, but the positive development shouldn't be ignored. So this is in brief what I have to say regarding the impact of COVID-19 on patient safety. I thank you for your attention, and will be happy to answer if you have any questions. Thank you.
All right, well, thank you very much. And I would like to then pose my question to the other panelists. And the question, to remind you, is what do you consider to be the most important prerequisite for meeting patient expectations in the new normal? So why don't we hear next from Marta, from the World Federation of Public Health Associates. Marta, what could you add that you didn't already say?
Yeah, so I guess the main intervention I would suggest are to use better the resources that we have. First, we need to invest more in prevention to make sure that we limit as much as possible the disease. There are a lot of means to prevent many chronic diseases. The risk factors are shared. We know what is healthy and what is not since decades, but we are still not able to convince our community to change behavior that are clearly unhealthy. Let's think about tobacco, lack of physical activities, unhealthy food, and so on. Second, I guess we should better use the human resources we have. We live in a world where we are all in silos, and we protect the silos of our own profession. And we need to be more open to work with the other profession, as I said also in my presentation this morning. We have all different competencies, and in most of cases we are not using at best all the competencies for lack of understanding of willing to share privileges, salaries, power, recognition. If we can, even within the health sector, in the care part, make a better use of the human resources we have, we will have a better follow-up and support to the patient. This is not just care, it's also psychological support, social inclusion, is making the patient that is sick with a chronic illness to feel part of a normal life. And this embeds what happened in the hospital, but also what happened at home, in the work environment. So it's very difficult, it's very broad, but we need to have a better coordination and better use of what we have. Thank you.
Karen, you represent nurses. Nurses have been an integral part of care during the pandemic, and nurses and healthcare providers in general have taken quite a beating over the last couple of years. So in representing the International Council of Nurses, what is it that you can add to how nurses and healthcare providers can meet the patient expectations going forward?
First of all, thank you very much, Andrew, for that presentation and that introduction. ICN, just for those of you who do not know the International Council of Nurses, we are the global voice of nursing, and we represent about 28 million nurses around the world. I'd just like to also congratulate the World Patient Alliance on convening this first World Patient Conference. It's really about time, isn't it? And it's a tremendous achievement, so thank you very much. Regarding your question, one critical prerequisite for meeting patient expectations in the context of the new normal is greater investment in the health and care workforce. Already before the COVID-19 pandemic, there were critical shortages of healthcare workers around the world. And now, according to a new study put out by the World Health Organization in the European region, 9 out of 10 nurses would like to quit their job. 80% of nurses had psychological distress. and 40% of doctors in the Euro region are approaching retirement. Now, the pandemic has made the health and care workforce shortage even more critical and much worse. And if it's not addressed, it could spell disaster. And as we all know, without a workforce, there can be no health care. So this is really one of the most critical issues that we face moving forward. And I think, if I could even say something about what's a prerequisite for meeting that expectation, that there will be health workers to meet patients. That critical element is political will. We need national governments, we need politicians who are really ready to translate what we know is the need in healthcare, that they see the shortage that we are experiencing and that is going to get worse, and they're able to translate that into policy and into budgets to invest more in health workers. Thank you.
Thank you. Risto, my wife is battling metastatic lung cancer, and she loves telehealth. She doesn't want to go see the doctor. She wants the doctor to look at her scans and then call her at home so she could sit at her desk and be comfortable and not have to wear a mask and not have to worry about crowds and waiting rooms, and she loves telehealth. But it's not all great, right? So why don't you tell us your impressions of this whole important issue, and how does telehealth play into this whole theme of new normal, new challenges for patients?
Thank you, Andrew. We did change a couple of words around this.
Yeah.
I represent the International Hospital Federation as past president and still an honorary member. So that is my point of view. And you're absolutely right. Telehealth can be excellent in many situations, and it has many areas where it saves time, saves energy and trouble for patients, but also the organization, the healthcare providers. But then again, you have to think about the circumstances. So let's take Africa as an example. I just attended a nice meeting around Africa. I think we have people from Africa here. Do you raise your hands? Good to see you.
We would have had about 40 more had there not been these visa issues. We had a huge sign up from Africa, but a big problem getting visas.
Oh, yeah, absolutely understandable. But the issue was that technically it's quite easy to connect patient with the doctor. You can tell what's the problem, doctor can give orders, but then if you don't have access to laboratory or x-ray or a supply of medicines, it doesn't really help too much. So in areas where these are issues, actually there are limitations. I might mention, just in a global perspective, Northern Australia is same thing. So very rural population, long distances, hard to reach. So you have to think about the infrastructure also. But in cases we heard and we mentioned, of course, it's very effective, time saving, and we have seen a huge increase in that, and certainly will be part of the new normal. I'm no doubt about it. Mm-hmm. But I don't really know if your old grandma would be willing to do that. I mean, typically the elderly population, let's say 80 plus, which is increasing, they are not that literate in using tele applications, not computer literate, maybe they don't have access. And they tend to have multiple morbidities. I mean, telehealth is excellent for a situation where you have a specific question like X-ray control, you just check it and then you move on. But if you have a person, and I think Penny put that out quite nicely, that you're talking to a person, you have to understand more than just a simple test result. And so my message in that respect would be that it is very good in some situations and in many situations, but you have to take into account other considerations as well in that. And just want to mention that I will be delivering another speech on emergencies and hospitals tomorrow, so I will not be touching on the issues mentioned there, so welcome to join me again. And I don't want to repeat what we just heard about staff shortages, about all restrictions imposed by COVID on health systems as well, not only patients and families, but the system providers themselves are affected. So this touches everyone, and we heard so much about it already. I don't want to repeat that.
Well, while we're on that topic, and thank you, by the way, but while we're on that topic, and I have the four of you, what is it that you think that stakeholders can do to improve the working conditions of our healthcare workers, to attract more people, and to make the statistics that your study showed about burnout and mental health problems and 90% wanting to leave their jobs? What could we do from the hospital systems, from the nursing systems, from the public health systems, and from government? So if I could hear from whoever on that. You want to start, Risto?
Well, in my opinion, there's a lot to do, and it's not necessarily about money, just being paid more. It is about the conditions of working, and this will be tough because now, as said, there's been an external disaster hitting, so not really caused by the system itself, but just something that's imposed on the whole system. So how to react on that? But we do have international experience in hospital leadership situations where the presence of leaders, I think you were calling for leadership in this, has been crucially important. Not paying more, not really that, but being present, taking care of your staff. And there are big differences worldwide in situations. So I would say leadership is one. And maybe just, it's a little bit out of this context, but I would like to refer to Sir Richard Branson, you know, the British multimillionaire entrepreneur. He says, customers, talking about customers, in this case might be the population of patients, but he said customers are not the first priority. Your people are, your staff is. When you take care of them, they will take care of your customers.
Right. Good point. Karen, you represented essentially all the nurses in the world. What's your take on this?
Yeah, I agree with what Risto is saying here. And the ICN is calling for a new, stronger alliance, a covenant almost, you might say, between patients and healthcare workers. And I think, in particular with nurses, we are calling for a new status, a recognition of the crucial role of nurses and nursing in the health and care and well-being of patients and people everywhere. We need a new appreciation and respect for the work that nurses and other health workers do, and nursing's unique contribution to people's health and well-being. We saw this during the pandemic. Patients need health care that is technically sound, scientifically based, but patients also need compassionate care. And then we also saw that during the pandemic. When cure is not possible, then patients need support to die with dignity. Tragically, so many patients have died with only the nurse to hold their hand, and at times patients were left to die alone. And this has been especially the case when family and loved ones could not be at the bedside to help care for their loved one in their final moments. Nurses grieve when they lose a patient, and witnessing the loss of so many patients in their care has been tremendously traumatizing for nurses and other health workers in the intensive care units. We need guarantees that nurses will be involved in decision-making. That is really a difficult situation, not just in healthcare policies, but also in policies in general. We also need sufficient resources, not just sufficient numbers of nurses and health workers, although that is critical. We need resources as well as including personal protective equipment that was lacking during the pandemic. We need ventilators. We need to know that they're there when the patients need them. We need medicines. We need access to continuous professional development for health professionals. So there are a number of things that need to be addressed in order to meet the needs of health workers We also need the digital tools, and Risto has told us about them, but they're not available to everyone. So that's a difficult situation. We also need fair and equitable pay. And I know that in Finland, where Risto comes from, we know that nurses went on strike, but the government threatened to take away the nurses' right to strike. And so many nurses in Finland have actually sent in their registration as a nurse, indicating to the government, we're through. We don't want to be nurses anymore, and take us off the registry. And this is what we need to avoid, just that kind of a situation where nurses are sending in and saying, I'm giving up. So meet the needs of the health and care workforce. That's the message to politicians. And we really do need the support of patient organizations to help us fight and lobby for respect and recognition. Thank you.
Well, you've got this patient organization behind you, that's for sure. And that's quite an answer, Marta. I don't know how you follow that, but you are in charge of all the public health associations around the globe. Tell us your take on how we improve the healthcare system for health workers.
So I guess on top of what has been already said that I completely support, we need to be practical. We need to change from the education level. We don't have enough healthcare workers, and we have a lot of blocks at the entrance in many universities of health professionals. First, these need to be reorganized. If the demand is higher, we need to be able to reorganize, to be flexible and to adapt to the system and make sure that we train the workforce we need. This, of course, is to be associated to the recognition that ICN just highlighted. And I guess this is the first step. And the second step is to make a mixed train of different professionals together during the university. We still train doctors, nurses, just to keep an example, independently, but they will have to work together all their life, and they don't know how to do. So education, university should adapt their training so there are some courses where they join forces, where they learn how to work together, when they learn each other's expertise to make afterwards, when they find themselves in a hospital, a better use of all the competencies available. And the common courses should also embrace communication, because they need to learn how to communicate among professionals, because it's very difficult. Just again, sorry to cite every time doctors and nurses, but they speak two different languages, and sometimes it's different to make the message clear going through. And second, to speak to the patient, and to speak also to the director of the hospital, to make advocacy for what is needed to the patient to increase their quality of life, their outcome out of what they are looking for in their time spent to face the chronic disease. And since many years, we are trying to find universities that are keen to take this challenge up. And as you may imagine, all the answers I got were too complex, no time. The structure is too fixed. So in case any of you is interested to take up this challenge, and as a good link with the university, I will be more than happy to explore together how we can make a real change in the education system. At least we start with one, and then maybe others will follow.
I love action points. I love takeaways and action points. So everybody do take advantage of that invitation from Marta. You may get a lot of emails. All right. We're getting close. Dr. Latif, tell us, certainly the WHO is very concerned about healthcare workers. Yes. What is their take? What is your take on this?
Thank you. I fully echo what has been done in terms of on the importance of health workers and their role into ensuring safer and quality care. For WHO, there is something, health workers is one of the building blocks, the key building blocks for health systems, and the whole framework for action supporting countries on how to develop and implement their national policies and programs for the the health workers, health workforce in general. There is something that needs also to be considered, learning from the the pandemic, which is the divide that we have between the health systems and the health security. Most of health systems are built in order to deal with the stable situations. But on the other hand, we face situations of emergencies, and we need to have this kind of a bridge between the health system and the health security. And this will enable and will lead to resilient health systems that will be able to deal with these emergencies and the crisis amid these tough situations. Regarding what WHO, I said that at the national level, we support countries on how to build this national policy and program for health workforce. At the institutional level, we have guidance, tools that, and we provide support on how to use these tools in order to ensure better occupational health, competencies, and fitness to practice, and all these based on the evidence, of course. At the individual level, I highlight the importance of education, and education shouldn't be only theoretical, but it should also be practical, meaning that besides the technical issues, we need also to teach them on how to communicate, how to partner with the patients, and these are key competency and key that needs to be further developed, mainly in low and middle income countries. Thank you.
Thank you for that. I'm going to open it up to the audience. In the last few minutes we have such a great panel here representing so many different stakeholders in the healthcare industry. There must be some questions. So if you could just raise your hand, we'll get a microphone over to you. If not, I've got lots more questions. Anybody? There you go. Just tell us your name and who you represent.
Good afternoon. Stalo Kyriakidou from Cyprus. We're representing the rare genetic diseases, but what I would like to say is that the chronic patient, it does appreciate the nurses because it's someone that we're dealing every single day. We see our nurses, the primary nurses, more often than our own doctors. So there is an appreciation from the chronic patients. And I think what COVID proven to all of us because of the health, globally, nobody was prepared, even advanced societies or economies, or less advanced economies. So something went wrong along the way, prepare for the pandemic globally, not just locally or regionally. So the problem was always there. So each one of us, the nurses, the healthcare system, they were mentioning their problems or the gaps. It's just the pandemic, it was too strong. So it came all in the surface. And we do have resources. A lot of resources. Yes, the distribution is important, but okay, let's say we change the distribution. The problem is monitoring the distribution of our resources. Who is gonna monitor them? WHO relies on regions or governments, which maybe they don't have the capacity, those resources to go to the end, to the patient, to the staff. So it's monitoring those resources, but an independent entity that is not involved with policy or politics, that we see those resources going down to the patient, going down to the healthcare workers, if leadership, unfortunately, when you involve them with politics, it doesn't get to the patient, it doesn't get to the worker. So it has to be dealt differently because we have seen that it's not working the way it is. We have changed policies, but still it doesn't work. So it has to do, how do we monitor those resources? That's how we feel about it. Mm-hmm. I don't know if somebody shares the same opinion.
Anyone have any thoughts on that? It's more of a comment.
I would just make a comment that resource allocation is always political. Mm-hmm. There is no way to do it in an apolitical manner. And the more that you try, the more political it actually becomes.
Wait, I thought it was all about the data. It's not about the data? Yeah. Yeah, that's an unfortunate reality, I think. Next, anyone else?
Hi, good afternoon. Paul Barish from the U.S. Karen alluded to this, but I'd like to invite the whole panel to respond. We talk about burnout, but that's really not the key driving force. The key driving force is what's emerging is what's called moral injury, which is around a breach in trust. And so healthcare providers in general, nurses in particular, feel the system has not respected the compact, not just about pay, but really about listening to them, engaging them, trusting them. So I'm curious from the various speakers, how do we deal with that? This isn't about more training or more money, like Risto said. It's really about thinking more carefully. How do we re-engage these people who feel that they've been betrayed by the system?
Who wants to take that first? And we have 2 minutes. Risto.
I would like to come back to the leadership issue I mentioned, because now what we see in hospitals in quite many cases are administrators and politicians, and are actually dependent on each other, and this is no leadership from my point of view. So the first thing that was already mentioned is trust. You need that in order to be a leader. Secondly, you need presence. If you're sitting somewhere in your ivory tower, you never get that. So we're talking about soft terms more than really the facts and figures behind it. And this is a big question. I refer to Karen's comments about the strike situation in Finland. I would say that was not exactly a best leadership in the world. And well, it's been solved now. They got into an agreement, but still, anyway, these factors are hard to define. What do you understand with leadership? And still adding to that we are working in multidisciplinary working groups. So this is not a medical line or nursing line. So this has to be understood.
Yeah, and you being with the International Hospital Federation, I would add the word culture to leadership. It's a culture
Absolutely.
And leadership, so that each of your individual members has to have a culture in that hospital that caters to the workers. And I don't know if your organization has put out any kind of calls to actions or toolkits or anything like
yes.
that. Yeah.
Quite a lot. Actually,
Where could they find that?
I'm teaching on that subject in the University of Colorado. So.
On the website, could they find that information on your website?
It's still in progress, but yeah, I will make it available.
Okay. Anyone else? We don't have much time left, but it's a great question.
Could I
Marta?
just add that adding to the moral injury of nurses and patients is the fact that many of the Western countries in particular are going to try to solve their shortage of health workers by going to poorer countries. And when we have our friends here from and representatives from Afro region, they're experiencing a tsunami of recruitment, aggressive recruitment of nurses and doctors from Africa to Western Europe, the US, etc. And now we know that the government of the United Kingdom has entered an agreement with the government of Nepal to recruit nurses from Nepal. Now, Nepal is on the red list of the World Health Organization. They have one of the lowest population ratios, as a nurse to population ratio in the world. And yet the UK is going to aggressively recruit nurses from their country. They have 600,000 nurses in the UK and 60,000 in Nepal. And yet the UK government feels that they can go to Nepal and recruit 100 nurses. It's very detrimental to the health of the population and the people of Nepal. The UK has resources to develop their own nursing workforce, so it's really disgraceful from the side of the UK government.
And if I could add,
we really need help from patient organizations as well in order to say that this is wrong. This is going to add to the moral injury that we already feel.
and to add to that, and I'll close out. To add to that, I would say that when you talk about those countries, that's where nurses are the primary care provider. There's not a lot of doctors. And here in the U.S., we have, multiple doctors, specialists, nurses, physician's assistants, And to take the primary care providers from these lower and middle income countries is just the wrong thing to do. But we are out of time. I wish I had all day to talk to these 4 experts. Let's give them a round of applause. They're excellent speakers, presenters, but we're out of time. So thank you so much to each of you for presenting.